How are you today? We will talk about a very important lesson in continuation of the lessons we started in cardiology, but Dr. Dr.abushama will present the lesson to us. Let us listen to him. How are you? Thank you, my teacher, Dr. Khalid Farag. Today we will talk about acute coronary syndrome. As we know, rupture of atheromatous plaque in coronary artery leads to thrombus formation, lead to vessel occlusion locally or elsewhere in the heart. The three types of acute coronary are saint elevation myocardial infarction, STEMI, high troponin and saint elevation on ECG. In practice, the saint elevation alone is sufficient to treat as the troponins take time to rise. Non-saint elevation MI and STEMI, high troponin and ischemic symptoms or ECG changes. Unstable angina, prolonged, severe angina, usually at rest, possibly with ECG changes. STEMI and unstable angina are often grouped together as non-saint elevation ACS and STIACs. MI type S classification by cause. Type 1, atherosclerotic plaque rupture. Commonest. Type 2, imbalance in myocardial O2 supply and demand, for example because of anemia, increase in heart rate, decrease in blood pressure, arterial spasm, embolism, or arrhythmia. May happen during surgery or illness. Type 3, sudden cardiac death with ischemic features on ECG, angiography, or autopsy, but before troponin could be checked. Type 4, MI during PCI. Type 5, MI during CABG. Okay, tell us about signs and symptoms of acute coronary syndrome patients, please. As we know, signs and symptoms of acute coronary syndrome: firstly, chest pain. And we evaluate chest pain using Socrates, that is mean, sight, central. Onset, usually sudden, but can be more gradual. Character, tight, crushing, but not sharp. Radiation, left arm, neck, jaw. Less commonly right arm, epigastrium, back. Associated symptoms: sweating, clamminess, shortness of breath, dizziness, faint, anger, anemia, and impending sense of doom. Timing, duration greater than 15 minutes. Exacerbating factors: exertion, emotion, eating. Relieving factors: acute coronary syndrome less likely if relieved by GT in less than 5 minutes. Severity, high but can atypically be low. Atypical presentations, more commonly seen in elderly or diabetic patients. Little or no chest pain, sobs, sweating, nausea and vomiting. Sometimes no symptoms at all, silent me. Signs: heart rate and blood pressure may be increase or decrease. PALRS 3 or S4 heart sounds, especially in STEMI. Okay, what is investigations you would do those patients to reach to diagnosis? Firstly, we will do ECG, do immediately, and if negative, repeat after 20 minutes, if pain continues or suspicion is high. See ECG findings in acute coronary syndrome. Troponin TRI, test on admission and are 3 to 6 hours. Troponin peaks at 12 to 24 hours, then declines over 10 days. Values greater than 99th centile are diagnostic of acute mild STEMI. Diagnosis is initially from the ECG alone so as not to delay treatment. Causes of high troponin: heart dies, HF, embolus, pulmonary, AF, renal failure due to low clearance, thrombus, acute MI, dissection of the aorta, inflammation, myo/pericarditis, exercise, very strenuous, sepsis. Other investigations: full blood count, decrease in HB may exacerbate heart strain, and baseline HB and PLT needed before anticoagulation. Urine and electrolyte, baseline before anticoagulants in assay, and screens for comorbid renal disease from hypertension. Glucose, tight control improves outcomes. Lipids, check on admission, as cholesterol can dip 24 hours post-MI. Chest X-ray, rule out other causes and check for HF. Exercise tolerance test, consider in low-risk patients. Thank you, Dr. Ahmed, for this important information and presentation about acute coronary syndrome. And thank you for all of you for your good attentions. And we will stop here today and we will continue the rest of the topic as the next meeting. God willing, with peace. Thank you.